Hello, KGR readers. It's great honor to introduce our research here. The title of our research is Changes in Automated Mammographic Breast Density Can Predict Pathological Response After Neoadjuvant Chemotherapy in Breast Cancer. My name is Jieon, a breast surgeon in Yonsei University College of Medicine in South Korea, the first author in this article. Introduction. Neoadjuvant chemotherapy is a beneficial treatment option for patients with breast cancer stage 2 to 3 disease or particular breast cancer subtype to improve outcome and quality of life. Mammographic density (MD) is known well as one of independent risk factors for breast cancer, and the dynamics of MD using sequential data have been regarded as potential biomarkers for prognosis, especially in patients with breast cancer treated with adjuvant tamoxifen. However, research on the association between MD and chemotherapy in patients with breast cancer is limited. Previous studies have suggested that NCT or adjuvant chemotherapy could reduce MD, probably as a secondary effect of chemotherapy-induced amenorrhea. Automated volumetric breast density (VBD) measurement is getting popular nowadays, which allows to promote objectivity and reproducibility. The commercially available Volpara and Contra software perform automated measurements of VBD and grade them similarly to the Mirage categories. Of the two, the Contra software measurement the total blast and fibroglandular tissue volumes by physically modeling, after which the percentage VBD is calculated as a percentage of fibroglandular tissue and total blast volumes. It generates four density categories by rounding off an estimate of the overall breast composition relative to the reference populations. Purpose. We calculated the percent changes in volumetric breast density delta VBD percent serially measured automatically using the Contra software. To evaluate delta VBD percent before and after NCT measured automatically using the Contra software and determine its value as a predictive marker of pathological response to NCT. 684 patients who received NCT followed by breast and XL surgery between January 2014 and December 2016 were enrolled. Exclusion criteria were patients with stage 4 at diagnosis, non-epithelial origin tumor, occult breast cancer with node metastasis, simultaneous bilateral breast cancer, age less than 40 years at diagnosis, male breast cancer, past history of contralateral breast cancer surgery, incomplete NCT at diagnosis, unable to undergo examinations for MD, either pre-NCT or post-NCT, or examinations for which the software failed to obtain quantitative values. 357 patients were selected for the final study population. Measurement of breast density. Standard radiolateral oblique MRO and craniocaudal CT views of mammography of contralateral breast. VBD was automatically calculated using the Contra software, which provided the volumes of the total breast tissue (VB), fibroglandular tissue (VFG), VBD percent, and quantized density (QABD). The pre-NCT and post-NCT values of the non-diseased breast were used for analysis. Delta VBD was calculated as post-NCT VBD minus pre-NCT VBD. Delta VBD percent was calculated using the follow formula. Set delta VBD percent less than minus 20%, delta VBD percent between minus 20% or above and 20% or below, and delta VBD percent more than 20% as decreased, stable, and increased groups of delta VBD respectively. Pathological complete response (PCR) was considered to be achieved after NCT if there was no evidence of invasive carcinoma in the breast or metastatic tumors in the axillary and regional lymph nodes on surgical pathology. The association between delta VBD percent grouping and PCR was analyzed using univariable and multivariable logistic regression analysis. This graph shows distribution of delta VBD percent before and after neoadjuvant chemotherapy. As the 25% and 75 percentiles of delta VBD percent in our study population were minus 18.9% and 16.7% respectively. We used similar but arbitrarily chosen cutoff values for delta VBD minus 20% and 20% to divide patients into the decreased, stable, and increased groups. This table is mammographic characteristics according to the delta VBD percent grouping. At pre-NCT, the decreased delta VBD percent group showed significantly low VB and higher VBD values than the increased group. The VFG was significantly low in the increased delta VBD percent group than in the stable group. The decreased delta VBD percent group demonstrated a higher proportion of dense Q3 and Q4 in the QABD. After NCT, the VB and QABD did not differ among the three delta VBD percent groups. The decreased delta VBD percent group showed significantly low VFG and VBD values than the stable group. The mean delta VBD percent values were minus 32.9%, minus 2.1%, and 44.9% for the decreased stable and increased groups, respectively. Next table shows clinical pathological characteristics according to the delta VBD percent grouping. The decreased delta VBD percent group included younger age, premenopausal women, no history of full-term delivery, and larger tumor size. This group was significantly less likely to achieve PCR after NCT. There were no differences in BMI, age and menarche, marital status, breastfeeding history, or contraceptive use, hormonal replacement therapy use, nodal status, NC regimen, histologic type, histologic grade, or breast cancer subtype. Patients with a decreased delta VBD percent were more likely to undergo total mastectomy with borderline statistical significance. When a subgroup analysis stratified by breast cancer subtype was performed, the decreased delta VBD percent group had significantly low PCR rate in patients with the luminar B-like and TMB subtypes. You can see the changes in the VBD were not related to PCR achievement in luminar A-like and HER2 positive breast cancer in table 4 of our article. Those figures are pre- and post-sensitive mammographic images from a case of PCR associated with breast density assessment using Contra. The left images at pre-NCT and right images at post-NCT of a patient with increased delta VBD percent of left-sided breast and PCR of right-sided breast are shown. The VBD percent increases from 6 to 13. Next figures are pre- and post-sensitive mammographic images from a case of non-PCR associated with breast density assessment using Contra. The left images at pre-NCT and right images at post-NCT of a non-PCR patient with decreased delta VBD percent of left-sided breast are shown. The VBD percent decreased from 14 to 7, and residual cancer is visible. Discussion. The decrease in VBD difference to a large differences after NCT was considered as a poor predictive vector of PCR, especially in patients with lumina B or triple-negative breast cancer, dense breast, and premenopausal status. The degree of changes in volumetric MD could be valuable as a predictive factor of chemotherapeutic effect with achievement of PCR. MD or VBD decreased after NCT, and the higher MD at diagnosis was associated with the lower PCR rate. Aggressive breast cancer subtype, high-grade tumor, and the use of anti-HER2 agents with chemotherapy were significantly associated with increased PCR rates. Conclusion: chemotherapy with or without anti-HER2 therapy decreased the breast density, and delta VBD% was associated with the likelihood of achieving PCR after NCT in patients with breast cancer. A decreased delta VBD% after NCT may be an unfavorable factor for PCR, especially for the luminar B-like or TNBC subtypes. Automated measurement of delta VBD% can be considered when predicting treatment response to NCT and cancer prognosis. A larger study is required to validate our results. Thank you for your attention.